Madam, sharp 7 o'clock.
Yes, sharp 7 we can start. Still 4 more minutes left. And participants have not come yet. I think my audio is clear.
Yes, madam, it's clear.
Okay, sir. I think 2 minutes left for the class to start.
One minute left, madam. We can go ahead at 7
Mr. Pulkesh, your voice is breaking. Dr. Suchait Bhatt, can you just tell me whether you can hear me or not?
Yes, ma'am.
Okay, is that clear?
Ma'am, I can hear you.
Yeah, thank you. Thank you.
Yes, ma'am, the voice is clear.
Okay, I hope there is not much lag.
No, ma'am, there is not.
Okay. Okay. You are in which SEM, doctor?
Ma'am, 9th semester.
9th semester. From which college?
Ma'am, NIMS Jaipur.
NIMS Jaipur. Okay. So online classes are going on for you, Dr. Suchait?
No, ma'am. It has stopped now.
Okay, like your syllabus got finished or something?
Yes, ma'am. It got.
Okay, have you
Ma'am,
finished your, yeah,
school- ma'am, the colleges are now reopening from tomorrow.
from tomorrow? Okay, okay. Have you reached your college?
No, ma'am. Tomorrow I'm leaving.
Okay, okay. So in the group, you can update me like how your people are going to conduct the classes, and so that I am enthusiastic, because our universities are still yet in the process of opening the colleges, and they have given the guidelines. That's it. So you can update me by the WhatsApp group.
Okay, ma'am. Definitely.
Okay, okay. I think it's better we start recording, Mr. Pulkesh.
హలో జ్యోతి
Yeah, Ramya.
హలో
Ramya, చెప్పండి.
జస్ట్ ఏలే జ్యోతి పుల్కేష్ ఇంకా రాలేదు అతను
ఓకే.
ఒక్క నిమిషం ఫోన్ చేసి అడుగుతాను
పర్లేదు, అంటే రికార్డ్ చేసేది ఆయనే కదా?
అతనే అతను ఫోన్ చేసి చెప్తాను జ్యోతి.
ఓకే, ఓకే. Dr. Srinidhi is from? Srinidhi.
Chanpatna, Bangalore only, ma'am.
Okay, okay. You are a MBBS student or a PG preparing?
MBBS, ma'am.
Okay, which sem?
Ma'am, 9th term, ma'am.
9th term. Okay. Which college?
Kempegowda Institute of Medical
Okay,
Science, Bangalore.
KIMS Bangalore. Okay. So your colleges are also reopening?
Ma'am, they have still not notified, ma'am. It should come from RGHS, no, ma'am.
Yeah, yeah. The other participant, Dr. Suchet Bhatt, is telling that they are shortly they are going to open their college, Jaipur. So
Okay,
that's
ma'am.
why. So in South, I think they are still hesitant to open the colleges, reopen.
Yes, ma'am.
So today's topic is urolithiasis actually, okay, excluding urinary bladder calculi.
హలో జ్యోతి, కెన్ యూ హియర్ మీ?
Yes, yes, I can hear you. వినిపిస్తుంది. I can hear you, Ramya.
పుల్కేష్ ఫోన్ చేశాడా జ్యోతి?
లేదు, రికార్డింగ్ చేస్తాడా లేదో తెలియదు. స్టార్ట్ చేశాడా తెలీదు.
అతను యాక్చువల్లీ ఫోన్ కనెక్ట్ కావటం లేదు జ్యోతి. జస్ట్ సెకండ్ ఇంకోసారి ట్రై చేస్తాను.
ఓకే. ಪುಲ್ಕೇಶ್, ರೆಕಾರ್ಡಿಂಗ್ ಸ್ಟಾರ್ಟ್ ಮಾಡಿ.
Ma'am, you spoke Tamil or Telugu, ma'am?
Telugu, Kannada. I know both. I can understand Tamil and Malayalam.
హలో జ్యోతి.
Yeah, Ramya.
Start జ్యోతి. You can start జ్యోతి.
Yes, I can start. Okay, thank you. Okay, doctors. Today's topic is urolithiasis. Okay. In today's class, I'm going to deal about what are the different calculi, where can they form in the urinary system, and how they can descend, what is their composition, and what are the differences between different calculi, what is their morphology, and what are the different clinical spectra created by each one of these urinary calculi. In today's class, I'm going to exclude urinary bladder calculi. Okay, that I'm going to deal in the urinary bladder topic. In the last class, we have dealt about different investigations in the urology, okay, like plain X-ray abdomen, CT abdomen, then intravenous urography, retrograde ureterogram, and so on and so forth. What are the different indications? What is the use of ultrasound? What are the indications and contraindications of IVU? Which method is being selected more often nowadays? So it is the CT abdomen that has taken its prime place in the investigation of any urinary pathology, okay? And there are certain investigations which aid you to arrive at a proper diagnosis, like complete urinary examination, blood picture, renal function test, creatinine clearance, okay? And simple investigations and other specific investigations which are specific for the different disease conditions, okay? So for the calculi, okay, as you all know, one second. Okay, first let's go to definition of urinary calculi. What is urolithiasis? The kidney stone disease is a condition where a solid piece of material occurring in the urinary tract forming from the substances in the urine. Okay, it is any solid material. It can occur anywhere. There are different parts of the kidney. Okay, like pelvic calyceal system. Okay, there is renal pelvis, the upper ureter, mid ureter, lower ureter, intramural portion of the ureter, urinary bladder, and then starts the urethra. So calculi can form anywhere. Okay. So depending on, so what is it? So it is any solid material of different composition and different morphology. It can be spherical, it can be spiculated, it can be hard, it can be a semi-solid. Okay. So it is any solid material occurring in the urinary tract. Okay. These may form in the kidney, ureter, bladder, or urethra. But ureteric calculi, usually they are descending from the kidney. Okay, so as such, the calculi forming in the ureter is very rare condition. Okay, so according to the epidemiology, it is more common in males. Okay, there are certain calculi which are more common in females. I'll be coming to it later. Okay, as such, the renal calculi occur in male population. That too, the age is 20 to 55 years of age. So in this age group and more common in males, the urinary calculi will occur. Okay, and it is more common in hot weather conditions where there is supersaturation of urine, dehydration, and the different composition of the urine, which will aid in the formation of the renal calculi. So it is common in young males, okay, and more in hot weather conditions. And to our grace, okay, we should thank the Almighty that 90% will be spontaneously excreted. Okay, so they will pass off spontaneously into the urine. So that is the luck. And there are certain other 90% in the renal calculi. 90% of the renal calculi are, can anyone guess? They are radio opaque. 10% are radiolucent. Okay, the same with the gallbladder calculi. 90% of the gallbladder calculi are radiolucent and only 10% are radio opaque. So these are the two, it is the just exchange of the statistical percentages. Okay, 90% of the renal calculi, that is the urinary calculi, are radio opaque. Only 10% are radiolucent, and 90% of the renal calculi will pass off spontaneously in the urine without any intervention. Okay. So these are the different parts in which the calculi might form. So they can form in the minor calyces, major calyces, and then in the renal pelvis and pelvi-ureteric junction, in the ureter, okay, and bladder, and so on and so forth. So they can form anywhere in the kidney. Okay, there are certain, what causes these calculi? Many scientists have made enormous research, and there are few universally accepted postulates so as to what can cause renal calculi and what precipitates what causes the first step in the formation of renal calculi. One of the most accepted postulates is this Carr's postulate. That means the microliths. So lith means, as we all know, it is stone, okay, any solid material. So initially, these microliths, they are like sand-like particles. They are sand-like particles develop in the subendothelial part of the urinary tubule. So the Carr's postulate states that they form in the urinary tubules And because of the multiple factors, they come and form in the pelvic calyceal system. And another theory is also is these are mainly the other contributory factors like vitamin A deficiency. If someone can tell me what are the epithelial protective substances, one is vitamin A, another one is, can anyone name it? So for epithelial regeneration, okay, immediately, so any epithelium will get de-epithelialized, so that will be destroyed. So immediately there should be formation of the new epithelium, among which the one substance is vitamin A, the next is zinc, okay. So vitamin A deficiency can also lead to calculus formation and also citrate deficiency, okay. Citrate keeps the calcium in the urine in the dissolved state. So it prevents supersaturation of the urine. So citrate deficiency can also cause urinary calculus formation and also presence of urinary tract infection. So the urea splitting organisms will form as a nidus and then leading to formation of different calculi. So vitamin A, citrate deficiency, and then constant recurrent UTI. It's not just one episode of UTI, but recurrent episodes of UTI, and then anomalies in the urinary tract also can lead to formation of renal calculi. Then there are certain metabolic conditions called hyperoxaluria and hyperuricemia because of the different metabolic disturbances. Okay, so one of the most accepted is microlith formation and then leading to the formation. So what are the other contributory causes? One is dehydration. So decrease in the intake of water can cause supersaturation of the urine, again microlith formation, and then formation of the renal calculus. So dehydration also acts as a precipitating agent. And prolonged immobilization. Prolonged immobilization, how it causes renal calculi is there is more calcium mobilization from the bones and then precipitation in the urinary tubules leading to formation of renal calculi. Okay, and also the renal tract abnormalities. So there could be many abnormalities like congenital constrictions of the ureter and then different this polycystic kidney disease. So many renal tract abnormalities can cause stasis or decrease in the flow of the urine leading to calculus formation. And also different mechanisms like erosion and deposition of urinary salts at the renal papillae, and the most famous hyperparathyroidism. As you all know, groans, moans, stones. Okay, so one of the causes is hyperparathyroidism. Then other condition called medullary sponge kidney, and then renal tubular acidosis. So these are the certain conditions which can predispose to formation of renal calculi. Why every human will not get renal calculi? There are different mechanisms and the metabolic build of a person. If there are these abnormalities in the person, so these can lead to formation of renal calculi. Okay. Coming to the chemical composition, there are different composition of the stones. It depends on the order, and the most common one is calcium oxalate. The other type of stones are calcium phosphate, and then there is a triple phosphate stone, which is also called as struvite. Okay, uric acid, cystine, xanthine, indigo, and then many drug-induced calculi of unknown chemical composition. So there are multiple, there is a spectrum of chemical composition, out of which the most significant one. So these constitute around 99% of the renal calculi. One is, the most common is calcium oxalate. The next common is calcium phosphate, struvite, uric acid, cystine, xanthine, indigo, and then miscellaneous one like drug-induced. Okay. So let's come to the stages of stone formation. Okay. One is supersaturation of urine. So urine consists of many electrolytes and other chemical substances which have been excreted. So first there is this hyper concentration, also called as supersaturation of urine. Next is the nucleus formation. So in order to stone to come into existence, there are certain parts of the stone called, one is the centralmost portion, that is nucleus formation, and then around the nucleus there will be multiple foci of small crystals. Okay, so there will be one central nucleus, and surrounding that nucleus there will be multiple spots of crystals. Okay, So initially in the previous class, we have learnt about the different crystals. So those crystals will aggregate. So that stage is called stage of aggregation. So now the crystals and the nucleus will aggregate, and then there is matrix formation. Once these crystals aggregate at one place, then the stone should be surrounded by the matrix. So one is supersaturation, the formation of the central nucleus, and the formation of multiple small crystals around that nucleus, and then aggregation of these crystals, and then matrix formation, so that the cementing substance will be laid in between these crystals and the nucleus, leading to the solid stone formation. So the stone can be of variable sizes. Okay, it depends on the chemical composition and also the part in which the calculus is forming. Okay, so supersaturation, nucleus formation, crystallization, aggregation, matrix formation, and then the formation of the calculus proper. So coming to the most common, most important, most symptomatic stones, that is oxalate stones. Okay, usually they are calcium oxalate stones. So these constitute around 75% of the total renal calculi. They are also called as mulberry stones. Okay, they are usually brown in color with sharp projections. Okay, they caused by usually due to supersaturated urine. There are certain food materials in which the oxalates are rich in, that is the wheat germ, spinach, beer. Okay, many people, many alcohol people will say that beer is a diuretic. Okay, it will cause flushing of the urinary calculi. No, it will rather precipitate the formation of the oxalate stones. So this myth has to be broken somehow. Okay, coming to the morphology. So this is the close picture of the oxalate stone. It has multiple very sharp spicules. Okay, it resembles the mulberry fruit. Okay, so these are the sharp spiculated edges of the oxalate stone. These white are the calcium deposits. So it is usually brown in color, have sharp spiculated borders. These are usually small. Okay, this oxalate calculi are usually small in the size. Okay, they usually do not attain very large size because they become symptomatic at a very early stage and can cause gross hematuria because of the damage caused to the urothelium because of the sharp spicules. So while they are descending, they cause tremendous pain. Okay, the colic will be very, very severe. They cause very severe pain and they cause very gross hematuria. They usually do not attain very large size like staghorn calculi and other calculi. They are usually smaller in size and most of this calculi will pass off spontaneously. Okay, so these are the oxalate stones. So am I clear till this point? Once we come to the MCQs, we have different compositions. Okay, next is the next most common is calcium phosphate stones. Okay, so this is because of the excessive intake of food rich in dairy products. Okay, there is a myth that if you drink a lot of milk or curd or a thing, so there is excessive formation of renal calculi. No, that is not true. But because of the excessive intake of the other processed dairy products like butter, cheese, so there is high chance of this calcium phosphate calculus formation, and it forms in alkaline urine. Okay, and again the supersaturation theory holds good for this. They are dirty white in color, so they are not pure white like pearly white. They are dirty white in color. They are smooth and solitary. So our oxalate stones are sharp, brown, spiculated. Okay, and these are dirty white in color. They are smooth and usually solitary. So if you see the gross appearance, so they have dirty white appearance. Okay, and then their edges are smooth, unlike the oxalate calculi. Okay, they are usually solitary. Coming to the most important calculus and the most complicated stone, that is triple phosphate, which is also called as struvite stones. Okay, better concentrate on this. So these are the composition of calcium, magnesium, and ammonium phosphate. That's why they're called as triple phosphate. So CAM. Okay, calcium, ammonium, and magnesium phosphate stones. So usually the renal calculi are more common in men, whereas These calculi are more common in women. Okay, these form more often in the presence of UTI. So urinary tract infections are more common in females. So they are more common in females with the history of recurrent urinary tract infection. And the organisms most often isolated are the Proteus. Please remember this, Proteus, and then later Pseudomonas. Pseudomonas UTI are more commonly associated with the presence of coexisting renal tract abnormalities. Okay, if there is any ureteric strictures or any constrictions, any abnormalities of the urinary tract, the Pseudomonas UTI are more common, and Klebsiella UTI are more common in diabetes. So Proteus, okay, Pseudomonas, and then Klebsiella. The most notorious one is this Proteus mirabilis. Okay, so what is their specialty? So they are very hard stones. Its composition is calcium, ammonium, magnesium, phosphate. Okay, they take the shape of renal pelvis, forming staghorn calculi. So do you know the animal stag? Okay, if you remember their horns, okay, they are blunted and they are irregular in shape. Okay, I'll just come show the picture. So if you see, they take the shape of the renal pelvis, and this is the pelvic-ureteric junction, and this is the upper ureter. Okay, the most proximal ureter. So are they taking the, so this is the plain X-ray KUB showing the staghorn calculi. After removal, see, look at this. So the same stone, after removal, it resembles the shape of the renal pelvis. They are very, very hard in consistency. So the usually the lady will be in sepsis. Okay, if you culture the urine and blood, definitely there will be growth of organisms, and these calculi, they take the shape of the renal pelvic-calyceal system, resembling the horn of a stag. Okay, it is like a deer, and it's a wild deer. Okay, so there is an animal called stag, so resembling its horns. So these are called staghorn calculus, which are also called as triple phosphate stone or struvite stones, more common in women and in the presence of urinary tract infection. Am I clear till this point?
Yes, ma'am.
Okay. There are certain other stones. Okay, one is cystine stones. They form in the acidic urine. Okay, this is due to cystine crystal formation. The rich sources are milk, cheese, and egg. So these are very hard stones. So please remember these certain points, okay, which will be helpful in answering the MCQs. Okay, they have less the ESWL. There is a procedure called ESWL, which I'll be explaining. The result with ESWL is very, very unsatisfactory because of their very hard in consistency. They are very, very hard to break. So ESWL is usually not that useful in the cystine stone treatment. Okay, there are other stones called uric acid stones, which again form in the acidic urine. They occur due to hyperuricemia. The rich sources of uric acid, which lead to excess uric acid formation, is one is meat and then red wine. Okay, and because of the chronic laxative usage, see, people post CABG patients or any liver disease, chronic liver disease, they will be on chronic laxative usage. They should not strain at stools. So chronic, or some people will have laxative abuse also. So such people, they are more prone for formation of uric acid calculi. So please try to remember certain salient points. So it has to immediately come in the mind. So cystine stones are formed in acidic urine. Okay, both this uric acid also in acidic urine, whereas the struvite stones are formed in alkaline urine. Okay, so it is due to the cystine crystal formation. Cystine stones are very hard to break, whereas uric acid calculi are radiolucent. Okay, coming to the MCQs. Yes, pure radiolucent stone is any guess? Struvite is definitely not, because you have just seen the picture. Struvite is triple phosphate. So cystine and xanthine and calcium oxalate. Calcium oxalate is the most common renal calculus. Definitely it is radio opaque. So you're stuck between cystine and xanthine. Any guess?
Xanthin.
Okay, xanthine. Okay, cystine here, it's a very hard stone. Okay, they are also radio opaque. So xanthine is a radiolucent stone. So the radiolucent stones are, one is pure uric acid stone. Okay, and then xanthine stones, and then indinavir. So where is this drug used?
Antiviral.
Yes, definitely it is an antiviral. Any specific condition you can think about? Usually used in HIV. Okay, so any
HIV.
yes, any HIV patient, so with who is on this drug with urinary calculus, these stones are usually radiolucent. So you have to subject the patient for intravenous urography to pinpoint the location of the stone, because they are not caught on X-ray or your conventional plain CT scan. So either you have to use contrast with CT scan, or even you can go ahead with intravenous urography where you can locate the calculus. Okay, so the radiolucent stones are pure uric acid stone, xanthine stones, and indinavir induced calculi.
Ma'am,
What is
one
pure?
doubt.
Yes, Chapandi. Yes.
Ma'am, radio opaque means we can't see on the X-ray,
Radio
ma'am.
opaque means you can see on X-ray. Radiolucent means they are black. You cannot see on plain X-ray. So radio opaque means they are white. Okay, once you take the X-ray, you can see those calculi directly in X-ray, as you've seen this place. So this is plain X-ray. So these are radio opaque. The white thing is radio opaque. Okay.
Yes, ma'am.
Okay. Renal calculi associated with Proteus infection. Very easy. I think you can answer.
Triple phosphate B.
Okay. So triple phosphate stones more common in females. Okay, with recurrent urinary tract infection. Okay. So these are your
Yes,
triple phosphate calculi. So they form in alkaline urine, whereas most of the other calculi form in the acidic urine associated with UTI and females. Not true about struvite stones, that is triple phosphate stone.
acidic urine, last D.
D option. So it is also called as Stagon calculi. Okay, and it is also triple phosphate stone. It is common in infected urine. So option D is wrong. So that means the answer for this is option D. So whenever there is calculus in the ureter, okay, the due to stone is caused by. So why should there be pain in the ureteric calculus? This was asked in AIMS. So single option. Any guess? What can cause intestinal colic or ureteric colic or uterine colic?
Stretching of the renal
We
capsule.
usually think that it is due to stretching of the capsule. No, it is not correct. Okay, it is due to increased ureteric peristalsis to overcome obstruction. So intestinal colic or uterine colic, so everything, the colicky pain is the excessive contraction of the muscle to smooth muscle to overcome obstruction. So the smooth muscle, it over contracts, thinking that there is some obstruction. If there is already obstruction, definitely it is going to go for colicky pain. So the answer is B. So what causes vomiting in colic? It is due to pylorospasm. Okay, it is not due to any other causes like sepsis or anything. So whenever there is colic pain anywhere, okay, it could be uterine colic or ureteric colic or anywhere. So such colicky pain will immediately contract the gastric outlet smooth muscles. Okay, so because of the reflex pyloric spasm, there is vomiting usually in case of colicky pain. So you will be seeing some ureteric colic. So every human, 90% of the world population, human population, will have at least one episode of this renal colic. Okay, so this vomiting in colic is usually due to pylorospasm. Okay, so if you see the nephrectomy specimen, so this is the cut section. What can you appreciate? You can appreciate something. So it is taking the shape of pelvic calyceal system. Can you identify? This was the image-based question asked. So what is this? It is taking the shape of the pelvis. Which calculus is this?
Stag on calculus.
Yes, definitely. So this is a very badly affected kidney. Okay, it has lost its function and probably it might have got infected. So they have done nephrectomy, and after nephrectomy, if you see the cut section, so there is a large stag on calculus. Okay. So coming to the what are the features of any urolithiasis? So what are the clinical features? One is most of the time they are asymptomatic. They are incidentally diagnosed routinely if they are doing ultrasound for any other condition. So incidentally they could be found out. And next, the most common symptom, if it once it becomes symptomatic, pain. Pain is the most common symptom of urolithiasis. Please remember this. Okay. Next, depending on the location of the calculus, the pain can be there. One is back pain. If it is pure renal calculus, pain is usually felt in the upper back. Suppose there is upper ureteric calculus, okay, or mid ureteric calculus, the pain usually radiates to groin, okay. Suppose if it is lower ureteric calculus, then the pain radiates from loin to groin, and also it is felt at the tip of the penis and inner aspect of the thigh. There could be dysuria, difficulty in passing urine, hematuria, blood in the urine, and then if there is stag on calculi or anything, there will be symptoms of urinary tract infection like increased frequency of micturition, burning micturition. There could be hematuria, okay. There could be fever with chills and rigors, and also depends on the organism and the extent of sepsis the person is in, okay. Then there could be vomiting, okay. Then increased frequency, and then hypertension. Very important, the secondary hypertension, you have to always exclude the renal problem. So be it any congenital anomalies of the urinary tract or any tumors, any renal artery stenosis, anything. So apart from that, the simple renal calculi can also cause hypertension. So secondary hypertension, you have to search for this. So when there is a hypertension patient, immediately the physician will order for ultrasound abdomen, if necessary CT abdomen also, in order to rule out this condition also. Okay. So if the urine is collected,
Ma'am, you told pain.
Pardon? Yes.
Ma'am, you told pain in the back means upper back renal stones. That can you tell, ma'am, radiating?
Okay. So if it is present in the pelvis, renal pelvis, okay, in the like major calyces, minor calyces, and up to the pelvic-ureteric junction in the upper kidney, okay. So then the pain might be felt in the back, just upper back of the patient, okay, because it has not descended yet. Once the stone starts rolling down, the pain will shift, okay. Once it shifts to ureter, the pain will radiate from loin. Loin means back, that is the sides to groin, okay. Once it starts descending further down, the pain will also start going down. So there will be loin to groin, and then tip of the penis, okay, and then inner aspect of the thighs, okay, through mediated through different nerves. I'll be coming to it shortly, okay. So what are the different nerves causing this radiation of the pain? If you see the specimen, so what can you make out? So there is gross hematuria, okay. So gross hematuria is usually caused by calcium oxalate stones because of its sharp spiculated nature, okay. Suppose if there is stag on calculus with recurrent UTI, the urine might be even cloudy and very foul smelling, okay. So there will be sometimes even frank pyuria also, okay. There are certain investigations you have to do. One is blood examination. I told in the previous class. So there should be complete blood picture, calcium, phosphate, creatinine, uric acid, blood urea, and then parathormone. If you are suspecting if there are recurrent calculi, you have to assess the parathormone. Any hyperparathyroidism has to be ruled out. So renal calculus diagnosis is not a great thing. The evaluation, the workup of renal calculus is very, very important. You have to first try to find out any primary cause. So just don't brush it away as supersaturation of urine. You did not drink water properly, so that's why calculus has formed. No, don't brush it away. You have to rule out different metabolic conditions which could have caused this renal calculi. So complete urine examination, as I told you in the last class, you can appreciate the cells, casts, crystals, and then microscopy. So from this, you can even guess the calculus which is going to form. So a simple urine examination can give lot of information, and the renal function tests have to be carried on so as to see how the renal function is. And then the investigation, suppose if you are going to do intravenous urography, the serum creatinine should be normal or it should be brought to normal, and urine should be sent for culture and sensitivity. If there is any urinary tract infection, there are three sepsis which you have to treat very aggressively. So I'm slightly going out of the purview. One is urosepsis, biliary sepsis, and sepsis in children. Please remember these three sepsis, you have to treat them very aggressively. There should not be any lax attitude from the physician. One is urosepsis, biliary sepsis, and pediatric sepsis. You have to treat very aggressively because the patients will collapse within hours. So treat the urinary tract infection, send for urine culture sensitivity. If there is any generalized sepsis you are suspecting, send for blood culture also. Treat the sepsis very aggressively, hydrate the patient, bring back the renal parameters if necessary, and please get the dialysis also done. Bring the renal function normal. Meanwhile, start evaluating if there is any hyperphosphatemia or any hypercalcemia or calciuria, hypomagnesemia, and look for the uric acid, parathormone, okay, and do the examination of the urine, okay, microscopy, and then the specific investigation. The simplest one is X-ray KUB, which can be done in the peripheral, even in the PHCs also. So this will catch the 90% of the radio-opaque calculus. As you all know, they are radio-opaque. 90% of the renal stones are seen on simple X-ray KUB. So with this, you can know where the stone is, okay, what is the size, approximate size, and its possibility of spontaneously passing, okay. CT abdomen will give you very precise information so as to where exactly is the calculus and what is the extent of the calculus, and then you can also serially monitor the patient also, okay. And then intravenous urography, it will also give the precise location of the calculus, okay. And then ultrasound abdomen, which is also next simple investigation. Of course, it is operator dependent. And then if you do this ultrasound, the other pathology, suppose any coexisting pathology is there, you can rule out them also. So USG, CTR, this can rule out any other abdominal conditions, okay. Next is cystoscopy, if there is any bladder calculus, okay. And then ureteroscopy, so visualization of the ureter from below, okay. You are going to pass a cystoscope and then enter the ureteric orifice. So you can go up to the almost up to the upper ureter, okay, by ureteroscopy, which is also called URS, okay. Then send blood and urine for culture and sensitivity. So these are the different positions of the patient. I'll be coming later. Just I'm giving you a small picture how a kidney can be approached. What is the different positions of the patient, and then what are the different incisions. During nephrectomy class, I'll be telling you what is a different position called, and how the incision goes, and what are the layers, and how do you retroperitoneally reach the kidneys and the adrenals. Okay. So coming to the, till now you have learned what are the different chemical composition, which are radiolucent stones, which are radio-opaque stones, which are sharp and brown, which are smooth, small, solitary, okay, and what are staghorn calculi. Now coming to different procedures, how to remove the calculus. As I already told you, 90% of the renal calculi will pass away in the urine spontaneously, okay, or by different medical management. Only 10% of the calculi will require certain interventions. So that basically depends on the site of the calculus, size of the calculus, and the urinary tract. Are there any abnormalities in the tract? Is there any possibility of the calculi getting stuck? Do you need one method or two methods in order to remove the calculi? Sometimes we combine different methods to remove the calculi, okay. So among which one of the most important and non-invasive technique, very famous technique for the calculus is ESWL. It stands for extracorporeal shock wave lithotripsy. So extracorporeal. So what each word has its importance. So extracorporeal. So you're not entering the body, okay? And then it is a shock wave. You are going to give some shock waves. And lithotripsy. Lithos means stone. Tripsy means breaking of the stone. So outside the body, from outside the human body, you are going to produce certain shock waves, and these waves are going to break the renal calculi. How can you produce shock waves? One is by different chemicals, like one is electromagnetic or piezoceramic shock waves. Okay, these shock waves pass through the stone, okay, through water as a medium. What do? They break the stone. The stones, either they pass off spontaneously. Once the stones are made into small pieces, they can pass off spontaneously, or they are retrieved through ureteric basket or cystoscopic removal. So these calculi can get stuck, or they will get retained in the lower ureter, and then you can do cystoscopy and then ureteroscopy. You can remove from the lower ureter, okay, one by one, piece by piece, or if they are falling, coming and falling inside the urinary bladder, you can remove them after you do cystoscopy, and then you can remove each calculus one by one, okay. It is usually done under C-arm guidance, okay. I think you all know what is C-arm. So this is the C-arm equipment. So this is an outpatient procedure. Usually there is no admission required for the patient, okay. This procedure can be undertaken under mild sedation, hydrate the patient adequately, and give liberal analgesia, okay. The operator should be protected well, okay. So there is a water bath, okay. So through these water bath, the shock waves will pass through, and then these shock waves, with the C-arm help, you are going to precisely locate the stone, okay. Okay, you're going to precisely locate the stone, and then you're going to keep the probe, and here the person will be pressing the button, okay. Literally, like if you have seen this ESWL, literally the sound will be like as if you are breaking the, at the construction site, you can hear that sound, no. In the same way, the shock waves are going to break the stone. You will get lot of noise, okay. So these stones will be broken, and they will either pass off spontaneously, or you can do a secondary procedure, that is URS, or you can do cystoscopy and remove the fragments of the stone. So this picture they might give in the exam, image based question. So what is this procedure? What are the indications? What are the contraindications of this procedure? And so on and so forth. So if you look at this picture, this is ESWL. Okay. So this is the principle. Okay. There should be something to visualize the stone, that is the X-ray. Okay. Then there should be a water bath as a medium. The production of shock waves. The shock wave should pass through the water. Okay. This X-ray will locate the stone, and then these shock waves will start breaking the stone. Once the operator will start pressing the button, the shock waves are produced, and the calculus, which is located by this X-ray receiver, and so that will show you the location of the stone. So all these will come into one diagonal position. Now the operator will start producing the shock waves. They pass through the water, and then the shock waves will, from without touching the patient, they will start breaking the calculus. Okay. So this is ESWL. What are the indications and what are the advantages? One is, it is a non-invasive procedure. Are you going to put your knife? No. So it requires mild sedation. It is done as an outpatient procedure, no need of patient admission. And immediately, once the patient is pain-free, he can even walk off, and he can even attend the duties. We have seen the patients even going to their regular duties within 1 hour of the procedure. And it can be used up to 2.5 centimeter calculi. Okay, so up to large 2.5 centimeter calculi, these can be broken. And this can be repeated many number of times, unlike any operative procedures where you have certain limitations. This ESWL can be repeated also. So this might require another 2 or 3 settings, or up to spontaneous passage of the calculus. You can repeat the procedure, but there are certain complications. So it is not free of any complications. One is hematoma formation. So the spicules, so there will be trauma to the kidney. So there can be hematoma formation. And the broken pieces of the calculi can also injure the kidney. Okay, so there can be hematoma formation, severe hematuria, and then retention of the stones in the ureter. So this is called strain stress. Okay, I'll be showing the picture shortly. Okay, so the line, so the broken, all the broken calculi will come and nicely sit in the distal ureter, forming a pearl of chain appearance. Okay, so that is called strain stress. Okay, and it is not so useful for large calculi. So more than 2.5 centimeters, they are not useful. And also for staghorn calculi, this procedure is not useful because it has different shape and the difficulty, there will be very severe difficulty of spontaneously passage of the stone. So they are usually useful for a large stone. Okay, fine. That too not that much hard stone, and up to 2.5 centimeter, 1 inch calculus, it can be used because it is a non-invasive office procedure. Mild sedation is required. It can be repeated multiple number of times. Okay. If you remember the previous slides, you can answer this. Which stone?
Struvite.
Okay, struvite is also one of the answers. But I think for this to answer, you should have paid attention in the last class. I told you calcium oxalate are one of the hardest stones, and out of which that calcium oxalate monohydrate is supposed to be the hardest stone to break. Okay, struvite are also hard stones definitely, but out of all these options, the hardest one is calcium oxalate monohydrate. Okay, sorry, sorry for this wrong answer. It's not coffin lid crystals. Okay, which is not a contraindication of ESWL. Actually, I didn't tell you in the procedure. Can you guess? Can you use it in uncorrected bleeding diathesis? Isn't it a contraindication? So suppose the person has bleeding disorder. You are doing ESWL and there is small fragmentation of sharp calculi. So they can cause massive hematuria and the patient can even go into shock, even though there is large formation of large hematoma. Okay. So definitely uncorrected bleeding diathesis is a contraindication. Pregnancy, definitely it's a contraindication because it's going to break even the fetal bones or skull. Okay. Definitely it's a contraindication. Okay. So pregnancy is a contraindication. Ureteric stones, isn't it a contraindication? Yes, sometimes the mid-ureteric or lower ureteric calculi, they are not amenable for ESWL. So ureteric calculus is also a contraindication. So ESWL is usually useful in proximal ureter and pelviureteric junction or pelvic calculi. So restricted to the kidney, you can use this ESWL, not for the ureter or the this urinary bladder. So you can use it even in calicial diverticulum. So if there is any calicial diverticulum, still you can use this ESWL. So the question is, which is not a contraindication of ESWL, is the answer is the stone in the calicial diverticulum. So these three conditions are definitely the contraindications of ESWL. So you understood the question and you understood the answer, no? Or you have any doubt? Okay. Is that yes? I can take it as yes?
Yes, ma'am.
Okay. Now coming to another famous procedure, that is PCNL. It is also, so it is abbreviated as percutaneous nephrolithotomy. So in the name itself, it is there. Okay. One is percutaneous. So you are going to, so it is definitely an invasive procedure. So you are going through the skin. Okay. And then you are going to remove lithotomy, nephro. So kidney, so it's not a ureterolithotomy, it is nephrolithotomy. You are going to remove the calculus. So as the name suggests, it is an invasive procedure, but it is a very minimally invasive procedure, not so invasive. Okay. As like open procedures, it is a minimally invasive procedure. So the advantage is you can use for the calculi which are more than 2 centimeter in size, 2 or 2.5 centimeters. So a large 3 centimeter or 3.5 centimeter, 4 centimeter calculus can be removed by this PCNL. Okay, it is also done under SIAM guidance. Okay, so there are certain steps. One is cystoscopy is done. So first you pass a scope through from the below, so urethra, and then cystoscope, and then stenting. You have to stent the ureter. Okay, next you are going to give a needle puncture through the loin, and then the pelvic calicin system is reached. Okay, and a guide wire is passed and opening is gradually dilated. You might be wondering what is she telling. Okay, so first what is done is, first you are going to put a stent from below. Okay, it is because the small calculi might come here and you have to drain the urine. Okay, for that purpose first do cystoscopy and then pass a stent. Okay, now you are at the loin. You can do it under spinal anesthesia, usually done under spinal anesthesia. Okay, you give a small 2 centimeter incision, then you pass a guide wire. So this is done under vision. Sometimes it is even a blind procedure also. You might even injure the pleura, because see the ribs are almost there here. You can injure the pleura and can cause hydrothorax or hemothorax. Okay, and then you can injure the pleura, even hemothorax can be formed. Okay, the surrounding organs, you can injure the aorta or IVC. So many catastrophes have occurred in the inexperienced hands or even in the unfortunate experienced hands. So give a small incision and then pass a guide wire. Okay, and on top of the guide wire you can pass the dilator. Okay, and then you will pass the something called as nephroscope. So once the guide wire is passed, the dilator is passed, on top of it you will pass this nephroscope. So this is the nephroscope. So through this the urologist is going to visualize the calculus, the pelvic calical system. So you are going to puncture the pelvic calical system and then the direct visualization, and then what you are going to do is there will be probe. There will be different shock waves, okay, produced. These shock waves will break the calculus. So there is a large calculus. The stone is going to be broken. There is an irrigation drain also. So there will be spontaneous irrigation will be going on. And then once the calculus is broken, it is removed through basket. Okay. So the surgeon will pass a basket and then he is going to retrieve it percutaneously. So first is guide wire under C-arm, dilator, on top of it this nephroscope, and then breaking of the calculus by different waves, either ultrasonic waves or piezoelectric crystal waves, shock waves, sometimes even laser is being used. So the stone is broken. Few small fragments might even pass through the ureter, and if there is larger fragments, they are removed by basket. Okay, so with small 2 centimeter incision, you are going to break the calculus and then you are going to retrieve it. So this procedure is called percutaneous nephrolithotomy. Okay, used for pelvic calical large calculi. So remember one thing, up to 8 mm calculus will pass off spontaneously. It is more than 8 mm calculus that will cause problems. Okay, so such calculi which are present in the upper urinary tract, these have to be either dealt with ESWL, which can manage up to 2.5 centimeters. If it is larger than 2.5 centimeters, you have to go for PCNL. Okay, so now can you please attempt this question? A patient with stone of size 3 centimeters at renal pelvis without hydronephrosis. The treatment is?
Yeah, percutaneous nephrolithotomy.
Yes, per PCNL, because it is more than 2.5 centimeters and there is no hydronephrosis. So even if there is hydronephrosis also you can do, because you can do the stenting from below and then you can do this PCNL procedure. Okay, and there is no hydronephrosis. It is present in the renal pelvis. Okay, the procedure of choice for this large calculus is PCNL. The laser used in renal calculi, you know different types of laser. Okay, the laser used in renal calculi for the urinary system is, any guess?
NDR.
NDAG is usually for ophthalm procedures, okay? So homium is the answer. So remember Sherlock Holmes, okay? For urinary calculi, the laser used to break the calculi is homium laser. If the stone is very large, or if there is any congenital or any distal obstruction for a large neglected calculus or for large staghorn calculus, which can neither be broken nor it can be retrieved by minimally invasive procedures. For such resistant calculi, you have to go for open procedure, that is called open pyelolithotomy. What do you mean by this? You are going to give a bigger skin incision and then you are going to cut open the renal pelvis and then the calculus is going to be removed. So I have shown you the different positions of the patient and different incisions, okay? Just so through posterior costal incision, the renal pelvis is opened, the stone is removed. Usually done for large calculi, more than 3 centimeters or even staghorn calculi. If there are multiple recurrent large renal calculi, you have done ESWL, you have done PCNL, and again they are recurring, at this time they have attained very large size, you have to go even for open pyelolithotomy. So open, that means it's an open method. It can also be done under laparoscopy. So through retroperitoneally also, you can approach through a laparoscope and then you can cut open the renal pelvis, you can extract the stone. So the kidney incision is given, the line of avascularity, okay, along this the incision is given, you are going to cut open the kidney, you are going through the avascular zone in the periphery and then you are going to remove the calculi, multiple calculi or even the large calculus can be removed. Okay, so from this you have got some idea. So which calculi are, what is the different chemical composition and then which are sharp, which are blunt, okay, which are radio opaque, which are radiolucent, and depending on the size of the calculus, what you can do. So it less than 8 mm, okay, they pass off spontaneously. More than 8 mm, okay, you can go for this ESWL 8 mm to 25 mm, you can do ESWL. Greater than 2.5 centimeter, you can go for PCNL for proximal renal calculi proper. Now coming to the ureteric calculi. So what are these ureteric calculi? Okay, they are always renal in origin. So these form in the kidney, they descend and come into the ureter and then they can either spontaneously pass off or they can get stuck or they can increase in size because of the deposition of other chemical substances. Okay, so what are the different locations at which the ureteric calculus can come and get stuck? Okay, one is the ureter crossing the iliacs, vas deferens at the level of vas deferens or the broad ligament in case of females, and then the distal ureter and also the pelviureteric junction, distal ureter and also the intramural portion. I told you in the previous class, the ureter before entering the bladder, it will pass through the bladder wall. Okay, there is almost 2 centimeter segment, okay, 1.5 to 2 centimeter segment inside the bladder wall. So that is called intramural portion. That is also most common part of the natural constriction of a ureter. So one is pelviureteric junction, ureter crossing the iliacs, vas deferens or broad ligament, the intramural portion, and the distal. It is also called as VUJ. You will be seeing the reports of radiology. Okay, your neighbors might be bringing. VUJ means vesico-ureteric junction. Vesico means it is the urinary bladder, and ureteric, that means the lower ureter and also the intramural portion. The usual symptom is loin to groin pain, hematuria, and then hydronephrosis because of the obstruction to the flow of urine, and there will be back pressure causing hydronephrosis. Now coming to the important questions. Okay, the referred pain in ureteric colic felt in groin from back to groin is due to which nerve? Can anyone guess? Are you there, doctors? Can you guess? Is it subcostal, iliohypogastric, ilioinguinal, genitofemoral? The answer is ilioinguinal. When there is pain in the distal ureter, felt in the penis or the medial aspect of the thigh, it is through the genitofemoral nerve. So the loin to groin pain is mediated by ilioinguinal nerve. What are the different investigations done for ureteric calculi? The most common is the CECT or intravenous urogram. Plain X-ray KUB also, it can show the renal calculi, ureteric calculi. But sometimes if there is any obscuration because of the bowel gas, you might not pick up. So you have to go for intravenous urogram or contrast CT or even helical CT. It will pinpoint the location of the ureteric calculi. Less than 8 mm calculi will pass away simultaneously, okay, spontaneously, okay. For different, there are certain procedures, okay. One is ESWL. Sometimes the stone is pushed up and then PCNL is done. So what happens is, in the upper ureteric calculus, you cannot remove by ureteroscopy, okay. So you have to push it in the renal pelvis. You can do ESWL or PCNL and then you can break it open. So let me come to the picture, okay. So this is a X-ray picture showing a radio opaque body. So it's quite large enough in the line of ureter. So this is the line of the ureter, okay. So this is probably a left-sided ureteric calculus. So this is the hydroureteronephrosis. So it depends, okay. Upper ureter, you can do flush therapy. Flush means you can give a lot of IV fluids and then give furosemide, okay, and then it can flush the urine. It is a primitive therapy. Most of the urologists do not recommend this because there is sudden precipitation of renal failure and severe hydronephrosis, okay. So usually this therapy is restricted to any small peripheral centers, okay. Then you can use it in peripheries, but not, this is not routinely used. So this is also called as flush therapy. Plenty of fluids and then giving furosemide, okay. Literally you are trying to flush out the stone. This can be used for small calculi like 5 mm, 6 mm or any calculus less than 8 mm, okay. Or reverse PCNL. So you pass a cystoscope and any guide wire, you push the stone which is impacted in the ureter into the back into the pelvis. Do ESW, break the stone and then remove the stone, okay. So this is called reverse PCNL. Or if the stone is very, very large, you can directly open the ureter and then remove the stone and then suture the ureter. So this is called open ureterolithotomy. Or you can even do ESWL or ureteroscopy. If the calculus is small enough, you can pass the scope through urinary bladder into the ureter and then you can remove the calculus. And for the mid-ureteric calculus, you can do ureteroscopy or even ureterolithotomy. And for the lower ureter, it's the most convenient, that is ureteroscopy and then Dormia basket. I'll show you. So this you are seeing from above, okay. You are going to pass, okay, the scope URS. You are going beyond the stone. You are going to open the basket. The stone will get caught in this basket. You are going to pull the stone out. So this is called Dormia basket. This is usually preferred for mid-ureteric calculi or most preferably the lower ureteric calculi. And there are certain other procedures, okay. You through cystoscopy, you are going to pass the ureteroscope. You can even apply laser or any shock waves. You can break the calculi and remove piece by piece, okay. So for ureteric calculi up to mid-ureteric and lower ureteric calculi, you can use this ureteroscopy and basket removal, okay. If they are very large, like more than 1 centimeter, and so for that you might need even open procedures. So as I told you, after ESWL, the small fragments, they'll form a queue in the lower ureter. If you can see this X-ray, okay. So bilateral, there is stagnation of the small bits of calculi at the lower ureter. This is called Steinstrass. They can cause massive hematuria and severe pain in the patient. So you can do URS and remove these fragments. Okay. So this is called post ESWL Steinstrass. The other procedures are laparoscopic removal and then nephrectomy. Sometimes if the kidneys are very badly affected and the kidney has become a bag of pus, you might even have to remove the entire kidney in order to save the body from sepsis. So one kidney is fine, functioning fine. The other kidney has totally become a pyonephros and it has almost the function is gone, means you can even go ahead with nephrectomy in order to save the body. Okay. And then you might have to do combined procedures like URS with the ESWL, okay, or PCNL with ESWL, so on and so forth. It depends on the condition of the patient and the location of the calculus. One small note about Stagon calculus is, it is, as you already know, it is a triple phosphate. It can be unilateral or bilateral, more common in females and in presence of infection. And these stones most often go unnoticed. The lady will come in last stages, usually in the stage of pyonephrosis. So you have taken some ultrasound or X-ray, it will show a large Stagon calculus. The lady will be usually with severe edema, okay, ascites and renal failure, severe uremia. And if at all she becomes symptomatic, there will be loin to groin pain and then symptoms of UTI with chills and rigors, frequency, or even complete renal shutdown. Okay, they usually present in very advanced stage. Okay, this is the Stagon calculus, which is typically taking the shape of the renal pelvis. The treatment of choice usually for Stagon calculus is nephropylolithotomy. That means you are going to cut open the kidney and also the renal pelvis, and in toto you are going to remove the Stagon calculus. Okay, there is a Brodell's avascular plane located at the periphery of the kidney. That avascular plane is called Brodell's avascular plane. Suppose if the calculus, this Stagon calculus is not irregular in shape. Luckily, it has got some shape. Okay, in that case, you can do PCNL. Suppose if the kidney is totally gone, then you can even go ahead with nephrectomy. So this is typical pyonephrosis. The kidney is nothing but full of pus. Yes, doctors, now I am open for questions. Yes, doctors, can any doubts?
No, ma'am.
Okay, because I think we have covered all the MCQs that have been asked. Okay, out of which the most commonly asked ones are image-based questions. Okay, they might show a plain X-ray or intravenous urogram. Okay, they might show even the picture of the ESWL or PCNL, and what are the indications, what are the contraindications. Okay, what is this stent? Okay, what are the uses of this stent? And then what are the complications of ESWL? What are the complications of PCNL? Coming to the complications of PCNL, there can be damage or injury to the pleura or even the renal capsule or surrounding structures, or major neurovascular bundle might be damaged. Okay. So these are the different complications of PCNL, as it is not a totally procedure under your control. It needs lot of experience and you should be able to deal with any collateral damage. So if you injure aorta or IVC, you should be able to repair. We have seen at least a neurologist in his lifetime, he might injure at least 1 or 2 aorta or IVC, definitely. Okay. So these are the different complications. Okay. I think if there are any doubts, we can sign off. Please try to read Bailey and Love, because urology is excellently given in Bailey and Love. And if you are more interested in urological procedures or something, please go ahead with Campbell. Bailey is an excellent book for urology. Please go and read now if possible. Okay. Okay. Thank you. If there are no doubts, I can sign off.